Thanks a lot for the invitation. It's my third talk on substance abuse treatment during this wonderful and well-organized Congress, and thanks a lot for having me here. As you just heard, I took over the chair of a big psychosomatic psychiatric hospital in Upper Bavaria called Chiemsee Blick, and that's actually the photo where the hospital is located. That's the Chiemsee Lake. That's one of the islands in the Chiemsee Lake where one of the Magic Kingdom castles of Ludwig II is located, and that's the hospital where I work. It's directly at the shore of the Chiemsee Lake. It's not the Mediterranean, but it's also a very nice area to work at. And that's the hospital itself. You see it's directly located at the Chiemsee Lake, and this was Obama visiting the area last year. I think most of you won't be too interested in alcoholism when it comes to the background. I would just like to spend the first few minutes on the history of alcoholism, and history really means history of alcoholism. I at present read an interesting book by the director of the British National Museum, and he describes the world history by looking at 100 objects which are placed in the British National Museum. And one of the objects located there is a 5,000-year-old tablet found in the today Iraq area where the war is. And this is one of the oldest written monuments in mankind which is preserved. And it shows, actually, it's a receipt. It shows, you see these amphoras here, there's beer in there, and it shows where workers are paid for 5,000 years ago in Mesopotamia, in the Iraq area. They were paid for their work by beer. This is one of the oldest documents of mankind already indicating that alcohol was very present at that time. And it's not only present on Earth, it's also present in space. This has been just released. That's a comet with the nice name Lovejoy flying through eternity, I may say, and it has alcohol on board. It has been shown that it's releasing about alcohol in the amount of 100 bottles of champagne equivalent per second. You have also alcohol in space, but you also have it on Earth, and that's what I'm talking about. A few words on diagnosis. In Europe, ICD-10 is still the major leader psychiatric diagnostic instrument, and we divide harmful use, damage to physical or mental health related to alcoholism or other drugs of abuse, and alcohol dependence. The core problem is the alcohol dependence. This is defined by 3 out of 7 criteria. If they are fulfilled, the individual meets the diagnosis of a dependence. The dependence spectrum per se is rather broad. It's composed out of psychological symptoms like loss of control, pharmacological issues, increased tolerance, or psychosocial sequelae of alcohol intake, persistent use despite harmful consequences. It's a broad mixture of symptoms under the umbrella of the dependence diagnosis, and this also means you have a very heterogeneous population to look at, especially when you look at studies. In the recently released DSM-5, this categorical distinction between abuse and dependence has been abandoned for a dimensional concept of substance use disorders. That's really an absolute new philosophy. All the symptoms which were displayed in abuse or dependence in DSM-4 or in ICD-10 have been combined, and there are 11 symptoms now which characterize a substance abuse or substance-related disorder. The only new symptom is loss of control among these 11 symptoms. All the others have already been named in DSM-4, but it's no longer a distinction between misuse or harmful use and dependence. It's just a spectrum of disorders, and if you fulfill 2 or 3 of these symptoms, you have a light, 4 to 5 symptoms, a moderate, 6 or more symptoms severe substance abuse disorders. You see these symptoms haven't changed a lot between DSM-4 and DSM-5, but it's combined now in one-dimensional concept. And for alcoholism, you see it here, 2 or 3 symptoms would be similar to what has been called harmful use before, 4 to 5 symptoms, a moderate dependence, severe misuse, 6 or more may be a severe disorder. Most of the patients we see, that's from one of the studies which have been conducted in this area, most of the patients we see or on the population level have 4, 5, 6 symptoms fulfilled. Very few meet 7, 8 or even more symptoms. So we have some few patients who meet all the criteria and many patients meet some of the criteria in the DSM-5 substance abuse spectrum. How's alcohol consumption worldwide? There are different figures on that. That's from the WHO official data. There are countries with a high consumption. That's Russia, that's Central Northern Europe, Central Europe, England, the United States drinks less, Southern America drinks less, and as you know, Arabian countries and also Asian countries drink less. The per capita consumption in most of the European countries, including children and the elderly, is about 9 to 10 liters of pure alcohol per year. When it comes to the number to be treated, that's just an estimation what we have in Germany. There are about 1.3 million people who have an alcohol dependence syndrome. Could also be 1.6 million, nobody knows exactly. There's a broader group of patients who have harmful use, 2.7 million, most of them are untreated, and there's a vast number of patients who drink too much, who drink more than they should do, without being dependent. They are at risk of developing a dependence later on. How much do you drink? Are you supposed to drink or not at all? It's a philosophical question, but it's also a clinical one. The WHO a couple of years ago defined classes of drink, and they were more reluctant than other groups. They set a low risk for alcohol consumption to develop some form of somatic or psychological disorder related to alcohol would be up to 40 grams of day in men and up to 20 grams of alcohol in women. Medium risk, 40 to 60 grams for men. High risk consumption up to 100 grams per day, and very high risk in men over 100 grams per day. That's quite a lot. Other statistics say 1 to 20 milligrams, just the half would be the limit. So there are different estimations and figures on that. The risk of becoming dependent, I've shown that slide already yesterday, is always dependent on various factors. One is the drug itself, the availability, its effect. The faster the onset, the higher abuse ability in general, the tolerability of the drug, then the individual predisposition. I believe in genetics, 40 to 50% of the abuse variability are mediated to probably hundreds of genes. Personality features play a great role. And of course, the personal environment, family, society, where you live, with whom you live, how your parents handle alcohol or not. Also, the microcosmos of world is also very important for the risk of becoming alcohol dependent. Psychiatric disorders, this was my first talk yesterday. I won't repeat the figures in detail, but psychiatric disorders per se also are risk factors for having an alcohol problem. We know from a number of studies that, especially in depressive disorders, that there's about 2-fold increased risk compared to the general population for becoming alcohol dependent. In bipolar disorder, it's a 6-fold or 7-fold increased risk, as an enormous potentiation of risk factors in bipolar disorders. And in schizophrenia, not here on this slide to be seen, there's a 4-fold increased risk. So the core of psychiatric disorders are also associated with a risk of alcohol intake. Genetics is an interesting field. I've been working in this area a little bit in the recent decades, and without going into detail too much, the origins of genetics, the very first papers published on that, had already to do somehow with alcohol. You know perhaps that the Mendel rules, Mendel was a Czechoslovakian priest in the 19th century who made his experiments in a monastery garden and crossing different types of peas. Why did he do that? Why did he do that? It was his aim to produce better plant cultivation, in the end to brew better beer. That was the major aim of the Brünn priest, why he looked into the genetics. So a little bit the origins of genetics had already to do somehow with brewing beer and alcohol. Today we have much better studies on the cause of alcoholism. We know from the twin studies that there is a higher risk of becoming alcohol dependent in monozygotic compared to dizygotic twins. We know if parents are affected, the risk of becoming alcohol dependent is greater in those who have one or even two affected parents than if your parent is non-affected, has been shown in many, many studies. And it has also been shown that if you have many offsprings or relatives with alcohol problems, the risk is also increasing considerably to develop an alcohol problem yourself. What's interesting is probably there's not a single gene to be involved in alcoholism, but when it comes to therapy research, there are a number of genes who may have a role in mediating the risk of becoming alcohol dependent. Probably the genes which are best studies, which have a high implication, are those which are involved in the metabolization and breakdown of alcohol and the pharmacogenetics of alcoholism. These are the alcohol dehydrogenase and related genes. This has been quite firmly established that genetic variations in this respect play a role. Other genes that may have some impact also on therapy of alcoholism are those which are involved in the control or cognition. Also, the MAO genes, serotonin, dopamine metabolism may be affected. Genes involved in mediating the rewarding effects of alcohol may play a role. Some dopaminergic genes, especially the DRD2 gene, has been studied in great detail, but also genes which code for opioid receptors, the OPRM1 gene, may have a role in this respect. Other genes are implicated in mediating stress and resilience and other factors. So these are genes that, by and large, in the end, may also be of relevance for future pharmacogenetic studies. Finally, an interesting finding from a recent Swedish national adoption study. You may argue that patients who have alcoholic parents, they learn from their parents that they drink when they have problems, so they will drink themselves when they have problems. That's, the argument is true, of course. But there are very interesting, especially Scandinavian studies, looking into adoptees, children who are not raised by their biological alcoholic parents, and they were compared to other adoption children without a biological background of alcoholism. And also in these children, the risk of getting alcoholic was higher, although nobody in their family, foster family, was drinking at all. It was about twofold increased risk for those who have the pure genetic background of alcoholic parents. So this is a clear proof for genetics playing a role in this area. Apart from alcoholism, also other factors of abuse like drug consumption, psychiatric or even psychotic illnesses, and criminal behavior was also more prevalent in the adopted children who had an alcoholic background. So an interesting research area is genetics of alcoholism. The economic sequelae of substance abuse in general, and especially of alcoholism, are enormous. There is this important global burden of disease study published a couple of years ago, and this indicates that especially in men, alcoholism is the most important and cost-intensive disorder. In women, it's unipolar depression. Drug abuse is also of some relevance, very expensive, but alcoholism, especially in men, tops all. So this is really a cost-intensive disorder. I will skip that. And there are some figures for Europe that a lot of traffic deaths, of course, suicides, cancer deaths, and other disorders are directly or indirectly related to alcohol intake. So a number of problems arise from alcohol intake. The probability of getting a disorder related to alcoholism rises with the drinks per day or with the alcohol consumption per day. The more you drink, that's the consumption per day, let's say 50 grams or 90 grams of alcohol per day. There is not a linear but an exponential increase of getting, let's say, alcohol-related injuries or other disorders. The higher the per capita consumption, the greater the risk of getting an alcohol-related problem. There are a number of meta-analyses on this, especially liver cirrhosis, which is the most frequent disorder related to alcoholism, has been studied in this respect. You know that liver cirrhosis or even liver carcinoma are very frequent in patients with alcohol-related problems and cause a lot of harm. In Switzerland, this has been studied in detail. I have been living in Switzerland for many years. And Switzerland, which has a German-speaking, a French-speaking, and an Italian-speaking country, there are 3 language groups in this country, the alcohol consumption is highest in those areas where they have wine production, especially in the French and in the Italian-speaking areas where there's wine production. The per capita consumption of alcohol is somehow higher than in the German-speaking countries or areas where they drink beer. Now, this is not a surprise, but if you look at the figures on alcoholic liver cirrhosis in this area, you also see that in the French and in the Italian parts of the country, where the per capita consumption of alcohol is highest, also the prevalence of liver cirrhosis is much higher than in the other parts of Switzerland. So this is a nice picture where you can see that in the population, the higher the alcohol consumption is, the higher the risk of having a liver cirrhosis. I could show you the same slide for traffic accidents related to alcoholism. That's absolutely the same. How do they count alcohol consumption in studies, especially in pharmacological studies? The American, or let's say English way at looking at it is not counting alcohol in grams per day, but they measure standard drinks of about 9 to 10 grams of pure alcohol per day, corresponding to 3 deciliters of beer or 1 deciliter of wine, and Americans count in 10, 12, 15 drinks per day. That's the way they handle the statistics. Okay. How much can you drink? There are some recommendations. More than 4 standard drinks a day in men and more than 2 in women is considered to be dangerous. As I said before, the WHO gives this figures, and it's always good to have some non-drinking days in the week to prevent the alcohol intake from becoming chronic. It's different to other psychiatric disorders. There are some estimates on how many patients with alcohol dependence are in treatment, and no surprise, most patients are not in treatment. About 90% are not in treatment, different to patients with schizophrenia or bipolar disorder who are causing so many problems that they, in one way or the other, are seen by a physician at least once. For most patients with alcoholism, that's not the case. I will skip that. There's always a debate when it comes to therapy research in alcoholism. Should the patient not drink at all, or is it okay not to drink as much as before? Is it okay to have some form of controlled drinking? This debate is accompanying my whole career for the last 30 years, and for the next 30 years it will go on. There are some good arguments against controlled or social drinking. First of all, loss of control is one of the key features of alcoholism and probably fixed in the central nervous system, so it will probably not getting revised. Loss of control is essential, and this argument against controlled drinking. The individual who will not get satisfaction from small amounts, let's say, of alcohol, will try to drink more. The reward system of the brain will say, I want more, and there are needs awakened that are not satisfied. So with alcohol abstinence, you are always on the safe side, especially when it comes to severe alcohol dependence. There are some few long-term studies on the risk of getting alcohol dependence. The most important one has been conducted in the late 1930s in the United States, in Harvard, near Boston. In this year, John F. Kennedy was at Harvard. And in Harvard, an interesting study was initiated by the local head of health services, who wasn't interested in alcoholism probably at all, but he looked into happiness. He wanted to see which individual will be happy on the long run and who will not be happy. And he included in this long-term study about 268 healthy, normal students with a good family background, those who could afford Harvard at that time, and included them, and they had no theory behind it, but were measuring all biological, somatic, and psychosocial variables they could at that time, from blood pressure to psychological domains. And it was sponsored by a local department store owner. And later on, this study was taken over by George Vaillant in the 1960s. And the whole sample was studied for about 60 years, a lifelong study. They know all about the samples for many, many decades. It didn't have a theory. That's like in genetics. That's one of the advantages. You don't have a clear-cut hypothesis. There was a lack of the theory. And they were measuring all the variables. In the end, I will be brief about that, a third of those individuals with a very good family background had some form of mental disorder in their lives. So also these individuals were affected by mental disorders. About 8 to 10% had an alcohol problem. And when you looked at those who were having an alcohol problem later on and compared baseline findings, nothing really showed up. Just one of the cases I brought for you, a Harvard graduate, written down best circumstances in family, educated parents, personal staff at home. According to social researchers, at home only happiness and harmony. This was a baseline when he was 18-year-old. Follow up 20, 30 years later, they found in the psychological description personal stability, he was intelligent, good judgment, very good health, firms, objectives and ideals as a perfect son, so to speak. And in the end, what the problems with women, alcoholism, at the end a desolate peace demonstrator, died suddenly. That's one of the many individual cases in this study, so nothing would show into the direction of a later alcoholism. When you look at all the psychological data, to be brief, nothing really shows up. There is no firm alcohol personality. You couldn't really predict which individual would be later on alcoholic or not. No relationship to depression, a little relationship to hypomania or psychopathy scales in the MMPI, but all in all, taken together, it's virtually impossible to predict who will have a substance abuse risk later on and who not. What this study also showed, and this is for treatment research essential, 60-year follow-up study, that if you were looking at those who had an alcohol problem, many of them died. It's no surprise, high mortality rate in alcoholism. A third or so became abstinent some way or the other. About a third didn't drink alcohol anymore. And a very small group, just 1% or so of the sample, turned up to be social drinkers or controlled drinkers in the end. So there's little between becoming abstinent, quitting alcohol consumption, or dying very early. So there are very few active or controlled drinkers on the long run. We know a lot about the neurobiological basis of alcoholism and of other drugs of abuse. They all act via the same areas in the brain. There is this basically dopaminergic reward system in the mesolimbic brain area. Drugs of abuse like heroin, alcohol, cocaine, and many other drugs directly or indirectly target this dopamine system. This is essential for natural reward stimuli like food, drink, having sex, nurturing, all these things which release dopamine in the nucleus accumbens are considered to be positive, pleasant. These are rewarding effects, and drugs of abuse stimulate these natural reward systems. Has been shown in a number of experiments, and we know quite well that a number of neuronal structures are involved in this rewarding processes, basing the nucleus accumbens and the ventral pallidum in the brain, but also amygdala and hippocampus for memory and learning system. Motivational areas on the orbitofrontal cortex plays a role, and especially and least studied to my understanding is the prefrontal cortex. This is the area where there is some form of cognitive control about the effects, the pleasure effects, the rewarding effects of drugs of abuse. These are the brain areas demonstrated on this picture, which are relevant for the treatment of alcoholism and for the rewarding effects of alcoholism. That's the same for most of drugs of abuse. We know from a number of fMRI and other imaging studies that this reward system can be activated in abstinent alcoholics much more stronger than in non-affected persons if those individuals who had an alcoholic background are confronted with alcohol-specific stimuli, like this one from Bavaria. The brain is much more active, will be much more activated than the non-affected individual, so you can really measure the effects of the reward system in the brain quite strongly. And it's not only the drugs affect this brain system, it is the anticipation of a reward. I anticipate to have a drink after my presentation. I anticipate to have a drink when I go to a bar. Already leads to an activation of this reward system. It needs to be fed in a way, so their alcohol is expected. So this is the way the reward system works in the brain. And for all we know, many of the drugs, there are so many drugs of abuse endlessly, but for all we know, basically all these drugs end up working through the same reward system, and this is just the neurochemical basis or the neurotransmitters involved in the breakdown of or in the mediating psychotropic effects of drugs of abuse. That's in the end always dopamine release in the nucleus accumbens here and in the ventral tegmentum area. Some drugs do directly stimulate dopamine release. Others, like alcohol, does it indirectly via opioid or GABAergic neurons. But in the end, they all end up in the release of alcohol. I skip that for time reasons and go into the therapy research. Just a second. Alcoholism is one of the best studied disorders when it comes to psychotherapy, psychosocial treatments. There are endless and numerous studies on how to treat and whom to treat. One of the textbooks you may be interested in is one of Mats Berglund. There are others as well. Encyclopedic literature on how to treat alcoholism. What we know, of course, is that psychotherapy or psychosocial therapies are effective in alcoholism. Has been shown in many, many studies. When you look at meta-analysis, you see that very intensive inpatient treatments may end up with abstinence rates after 1 year or so of 40 up to 50%. 50% is probably a little bit optimistic, but the best treatments after a year or so show abstinence rates of about 40%. That is what you can realistically expect from very intensive inpatient treatments. Many statistics are even worse, showing up 20 or 30%, but the best ones about 40%. So you can treat alcoholism by psychotherapy, but you will have a lot of patients who relapse, as other psychiatric disorders also relapse. The prognosis in alcoholism is better than in other studies, let's say on opiates or cocaine. There's this wonderful meta-analysis by Dutra and colleagues who looked at that in much detail, showing that even the retention rate was low in those studies. You had 37% in opioid dependence, drop out of treatment. In cocaine, it's even 40%. In alcoholism, it's about 15 to 20%. Also the prognosis when it comes to psychosocial therapies is better in alcoholism compared to so-called illegal drugs. We have some elements of psychotherapy we know that are effective in. This is don't look into the figures. That's a list from different meta-analysis by Finney and Monahan or by Harold Holder, who made a list of elements who are effective or not effective in the psychotherapy of alcoholism. Let's say stress management is effective, couples therapy is effective, some form of social competence training is effective in alcoholism therapy. There's a broad spectrum of cognitive behavioral elements that are effective. Psychoeducation, just mediating knowledge about the effects of alcoholism, has a rather weak effect size. It's not too effective. Unspecific group therapies don't have much effect in alcoholism. And if you have a therapy that's basically very confrontive, as looking at the patient, you are a liar and so on, they have even negative effects on treatment outcomes. So you better stick to those elements here than to those elements here. A very confrontive way of therapy is not very effective. Most of the studies have been conducted in residential treatment settings. I myself, a couple of years ago, we have done intensive outpatient treatments of alcoholism. We looked at a sample of patients over the three-year period of 100 patients who had been in treatment for 9 months, 3 sessions a week. And in the end, we defined whether they were abstinent, had some form of improved outcome, or had relapsed. And if you look at the data after 2 or 3 years, you see that there's an abstinence rate of 56% after intensive outpatient treatment after 2 years. After 3 years, it was 44%. A small group who had an improved outcome, and about 27% relapses after 2 years, 40% after 3 years. So these are the figures you, by and large, find in a number of studies. Motivational interviewing or other psychotherapies are today standard when it comes to treating alcoholic patients. Not to be too confrontive is essential, some form of empathetic attitude and going with the patient and not against him. What do pharmacotherapies add in this place? We quite recently finished up a big meta-analysis and evaluation of existing therapies. We evaluated also pharmacotherapies, and has been written in a textbook about that. Those medications or treatments per se who have a strong evidence are class 1 medications, moderate evidence, class 2 evidence, and if there is a weak evidence, it's class 3 or 4 or 5. That's what we defined with treatment recommendations. When it comes to psychotherapy, as I said before, behavioral therapies, contingency management, couples therapy, and so on, quite a good level of evidence. How look pharmacotherapies? I'm looking to... Okay. There are not too many pharmacotherapies when it comes to relapse prevention of alcoholism. One of the pharmacotherapies available, I'm not sure whether it's on the market in Turkey as well, is acamprosate. That's a drug which has an unclear mechanism of action. We always believe that it is acting via glutamatergic neurons, but it's not essentially clear how acamprosate works. It has been introduced into the market about 20 years ago, and there's a broad number of publications, that's from a meta-analysis, on acamprosate, including our own, Sass et al., published in the Archives of General Psychiatry 20 years ago, all compared acamprosate, 6 tablets a day, bad bioavailability, compared to placebo. If you look at the end, you see that acamprosate reduces the risk of alcohol consumption in recently detoxified alcoholics. The risk is reduced to 85%. Number to treat is about 9. So this is a moderate but clinically relevant effect size. You can see in this meta-analysis that acamprosate, Campral is the name of the drug, reduces the risk of alcoholic relapse in individuals. It's not used very much, but the database is quite clear. For acamprosate, you see a lower relapse risk when compared to placebo. The same in this, you can look at the abstinence rate or the risk of heavy drinking. This means if you drink less than you would drink when you have been drinking before. Also, the number of drinks per day is reduced. Also here, you see a small but significant result in favor of acamprosate compared to placebo. So this is one of the drugs you may use in the treatment of alcohol dependence. Even more intensively studied has been the opioid antagonist naltrexone. Naltrexone is available as a tablet, 50 milligrams per day, is antagonizing the opioid receptor completely. There's also a depot formulation, but it's only available in the United States, to my knowledge. Naltrexone blocks the rewarding effects of alcohol. Alcohol stimulates the opioid receptors, including the mu-opioid receptor, mediating rewarding, euphoric, pleasant effects. And if this is blocked, it is probable that the individual will drink less when he's under naltrexone. Naltrexone has been studied intensively. There are numerous studies on that. And when it comes to risk of heavy drinking, it has also been shown that the number of drinks, also the alcohol consumption per day, is reduced when the patient is under naltrexone. Not so much the abstinence rates, but the risk of heavy drinking after a relapse to alcoholism is reduced in naltrexone. This is also approved, the medication, in most of the countries, at least in Europe and the United States. It's not giving to a large extent, but there is some rationale behind it. Rewarding effects blocked by naltrexone. This is one of the alternatives you may have. When you look at side effects, that's from our own Cochrane analysis on acamprosate and naltrexone, published a couple of years ago. With naltrexone compared to placebo, you only have a higher rate of diarrhea for unknown reasons. In most of the cases, it will vanish spontaneously, but some patients suffer from that. That's more frequent under acamprosate compared to placebo. In naltrexone, you have a different picture. Naltrexone may cause some form of gastrointestinal effects. It's not tolerated by all of the patients quite well. Dizziness has been reported, reduced appetite, nausea, to my understanding, is probably the most relevant side effect. Nausea is quite frequent in naltrexone, stomach ache. So about 6 or 7% of patients have some severe side effects with naltrexone, and by and large, apart from dizziness, it's gastrointestinal side effects with naltrexone. There are some more recent meta-analysis. That's one published in the Journal of the American Medical Association in 2014, evaluating the same medications. They ended up in saying acamprosate outcome either return to any drinking or to heavy drinking, or the number of drinks per day. These are complicated mathematical models. If you look at it, you have moderate effects of acamprosate on much of the outcomes related to alcoholism. As I said before, the same we found in our meta-analysis. Disulfiram, that's the eldest medication available for treatment of alcoholism. Disulfiram blocks the breakdown of the alcohol aldehyde dehydrogenase, ADH, a difficult word, and this is causing flush, unpleasant feelings, high blood pressure. So if you block the breakdown with disulfiram, you get very, sometimes even dangerous side effects. This is an old medication. It has also been studied with respect to return to heavy drinking or any drinking at all, and so on. And the evidence, if existing, is low or insufficient. This is still available, the medication, in many countries, but the database is not too convincing. I will show you a slide for this later on. Naltrexone 50 milligrams oral, moderate effect sizes in all of the variables studied. As in our Cochrane analysis, there is some form of evidence for oral naltrexone, and for the depot naltrexone, not available in Europe, there is only a few studies published so far with a low efficacy proof. So these are the medications available at present. In brief, you would say acamprosate rather supports abstinence in alcoholic patient, naltrexone rather supports controlled drinking or reduction of alcohol intake. There are some novel meta-analysis always on the same drugs. I will be brief about that. The meta-analysis of Meisel et al. Published in Addiction, basically showing the same what we found and what Jonas found and others too. Is there something novel coming up? There are so many drugs that work in the animal model that will never make their way into the clinical practice. There are now some novel medications tested, and one has been introduced in Germany, that's nalmefene, another opioid antagonist which has a different profile compared to naltrexone. It has been developed in the 1970s. It has an antagonistic effect at the mu-opioid receptor and a partial agonistic effect at the kappa opioid receptor. It suppresses dopamine release in the mesolimbic reward system and has a half-life of about 8 to 10 hours, and as the other medications, no relevant interactions with alcoholism. The drug has been introduced by Lundbeck a couple of years ago. The chemical structure is quite similar to naltrexone. There's just one molecule different when it comes to comparing nalmefene and naltrexone. We know that, as I said before, nalmefene is, as naltrexone, is reducing dopamine release in the nucleus accumbens, probably by blocking the opioid receptors. This is clear. The role on the kappa opioid receptor is not really clear. There's a partial agonist here. Naltrexone is a full agonist at the kappa opioid receptor. We know from the animal model that the kappa opioid receptor may play some role in mediating motivational effects of substance abuse, but it's difficult to define what the different role of especially the kappa opioid receptor in alcoholism is today. Now, there have been, in general, 6 studies with nalmefene. 3 are important, the so-called eSense-1, eSense-2, and SENSE studies. The first 2 are classical randomized controlled trials with a large number of patients included, 600 or 700 patients included, placebo-controlled. These were 24-week studies plus a 4-week run-out. Conducted in many European countries. This is more a safety study in 700 patients. What was the methodology of these patients? First of all, it was a voluntary treatment. Patients could take the drug if they wanted, no fixed dosage. When they had the feeling they had a high-risk alcohol consumption day ahead, they could take the pill, but it was not a fixed dosage. And the treatment outcome was not the abstinence rate, as in all the other pharmacological studies conducted, but it was the number of drinks per day. And these were defined according to the WHO definition, very high risk consumption, 100 grams or more in men, 60 grams in women, and so on and so on. So the number of drinks or the gram of alcohol per day were measured in the end. Results. This was the study design, as I said before, run in, 6 months treatment, placebo controlled, and run out. Results. These are the figures on the 2 major studies, the high drinking days. As in all studies conducted with pharmacotherapies in alcoholism, you see a broad decrease of alcohol consumption immediately after study initiation. This is the same for acamprosate. That's the same for naltrexone. Medication, the decision to get into a study, the decision to do something about your alcoholism results in a massive decrease of alcohol consumption already in the placebo group. With nalmefene, there was some additional effect on grams per day, so the treatment outcome in the end was moderate but positive for nalmefene. You see here the reduction of alcohol consumption over the treatment period, and you see it was a moderate but significant effect in favor of nalmefene, causing less alcohol intake. The drug has been approved. It's not much given as the other medications in alcoholism, and the issue is still controversial. But excuse me, the interesting aspect of nalmefene is not so much its pharmacological profile, but the intention to treat patients in a deliberate way. They can take the drug, but they are not expected to take the drug on the daily basis, and it was the risk reduction aspect of this treatment which is of relevance. What is ahead? What is of interest at the moment is baclofen, a GABA-B agonist, which is used in neurology. There has been a textbook by Oliver Armeisen, a recently deceased French cardiologist who was alcoholic himself. He published his own case report, by the way, and he pretended to cure himself by very high dosage using baclofen, and this led to a number of studies which are ongoing. Baclofen, there are some believers in baclofen, not me, but there are some believers in baclofen, has been introduced in France, and apart from some pilot studies, there are 3 major studies underway now with baclofen, and we will know quite in the next weeks whether this is effective or not, but this is ahead, as baclofen has some followers. To finish up to give a complete picture, a final look into disulfiram. It is still available in many countries. In Switzerland, it was quite widely used. In Germany, it's now off the market because it's not so much given anymore. As I said, disulfiram has some very unpleasant effects when the patient drinks alcohol. There are few classical randomized controlled trials with disulfiram. There has been a recent meta-analysis in the Alcoholism Journal. If you look at unsupervised treatments, patient just can take the drug or not, nobody is standing behind him. There is no difference between placebo and disulfiram, especially shown in the studies by Fuller et al. This is better than in supervised treatment models. And in the end, prevention is best, not more than a glass of beer per day, and you won't get alcoholic. I skip to this time schedule. I'm ending up now, and happy to answer some questions if there are any. Thanks a lot.